Good afternoon, everybody. This is Dr. Anthony Levinson from McMaster University. My co-star, Dr. Richard Sztramko, geriatrician at McMaster and Hamilton Health Sciences. And welcome, everybody, to our 15th live event on sleep and dementia in our first live event for 2020. Today, we're going to be talking about a really key topic, this issue of sleep or lack of sleep, insomnia, and the variety of challenges that can occur with people living with dementia, and especially for you, the caregivers, in how you can cope when there are sleep issues with dementia. And as you know, the format of the session will cover some basics related to the topic of sleep and dementia. And then we'll go to questions. So please feel free to use the commenting section on Facebook, or if you're watching on our website, you can use the chat bot to send in your questions or comments or stories with respect to sleep and dementia. So why don't we get started? And let's just talk a little bit about some of the changes that happen to sleep with aging, because there are some. First of all, it's probably fair to say that sleep remains a bit of a mystery to scientists.
Absolutely.
Like, we don't fully understand everything about sleep and why we even need sleep, but we do know that there are some important changes that seem to occur with aging generally, and then some as well with dementia.
Sure. So as we age, people may find that they're not sleeping quite as well as they did previously in their lives. They may spend the same amount of time in bed, but may wake up more frequently, may have some difficulties falling asleep, and the overall time spent asleep diminishes with age. So your needs still stay the same. You'll still need to to get sleep, but you may find it a lot more challenging actually achieving sleep or staying asleep. People may complain of waking up slightly easier than they did before, as well. And so, on average, people may sleep 30 minutes less per night for every decade above the age of 50.
And this turns out to be a pretty huge issue, doesn't it? So,
Mhm.
and we'll talk a little bit. I guess one of the simplest things that we often think about when we think about insomnia
Mhm.
is, beginning, middle, end. So, insomnia or problems with sleep can happen um, at the beginning. So, you have problems falling asleep in the middle of your sleep where you're waking up frequently, and I guess that's one of the challenges that caregivers often complain about with the loved one with dementia, or people are waking up early and not able to go back to sleep. But I guess tell us a little bit about what caregivers talk to you about related to the sleep issue.
Sure. Um, a big challenge really is falling asleep for patients that have dementia. If there is a significant um, problem with sleep that's causing distress for both the person that has the sleep
Mm,
issues as well as the caregiver, it's usually lack of overall sleep. And it could involve any of those
okay.
things, and sometimes all of those things. Um, and we'll notice that if the patient is up, but perhaps wandering in the middle of the night or looking for various objects or watching TV, the caregiver may have a hard time falling asleep because they feel that they need to monitor that person's activities to make sure that um, nothing harmful happens to them.
So
And
they're
when you
sort of
have both people,
they're sleeping with one eye open,
exactly,
and they're worried about the person with dementia who may get into a safety issue or wandering. So neither person is getting any kind of quality sleep, or anybody in the household, I guess, might be affected
right.
by that.
And, with the person that has dementia, they have something happening in their brain, which is obviously causing cognitive impairment. But over time, day over day, if you're not sleeping as much, that worsens the cognitive impairment. And in fact, the people that are cognitively normal or the caregiver can actually start to have their own cognitive problems because they're having sleep deprivation in that sense. It can also worsen mood. as well. And we know if we measure your stress hormones over a period where you've been sleep deprived, your levels of cortisol can increase, your thyroid hormones get a little bit out of whack. And people will think of sleep deprivation as, well, I didn't sleep for an entire night. And that's going to cause a certain impact. But actually, people that have mild sleep debt, where they're losing 2 or 3 hours every night, if you measure it after 7 to 14 days, their cognitive impairment may be just as bad as if they had not slept an entire night.
Wow.
So people don't really think about the chronic low-level sleep debt as well, and it really throws your body out of whack.
So one of the things that we might talk about, there are a couple of the types of dementia that may have specific types of sleep problems, but I guess there's really a range of issues, some of which you alluded to already, that people with dementia might have that can disrupt sleep. So they may be waking up more frequently than normal. They may have a lot of problem falling back to sleep. And I think the big one that I hear about a lot is the safety one, where somebody is waking up. The person with dementia may be totally confused as to whether it's daytime or nighttime. They may be getting ready to start their day. They may be getting ready to go out of the house. And I think caregivers are really, really fearful of
making a meal in the middle of the night, right? Starting their breakfast or something like that. Yeah. The other thing I didn't mention also is, age is associated with dementia, and age is also associated with a lot of other medical conditions that can worsen sleep. So if you have heart failure, for instance, and you're lying flat, you may be more short of breath and waking up in the middle of the night because you're short of breath. People, men as they age, have enlarged prostates and will actually go to the bathroom much more frequently. So that can change sleep. Anybody that has a form of chronic pain disorder, they may find that it gets worse at night, or as the room is quieted down and they're not up to anything, they start experiencing their pain. So there are also a lot of other medical conditions that you need to be aware of and think about when people are complaining of sleep. In particular, in people that have dementia that might not be able to communicate very clearly what's happening in their body. And that's why a very detailed assessment of, well, not just that you're awake and wandering, but not dissimilar to the responsive behaviors that we've talked about, doing a deeper dive into, wow, that person's got, terrible knee arthritis or other things
pain
of
that they
nature.
might not be expressing,
pain that they can't clearly describe what's taking place or happening. Or if they're short of breath for a medical reason, they may be more agitated, they may be more confused, and that's exhibiting as a sleep disturbance when really it's a primary medical problem in somebody that can't communicate that to you.
The one of the conditions that I think has gained a bit more attention over the last decade is sleep apnea, particularly obstructive sleep apnea. Do you want to describe what that might look like for the caregiver?
Sure. So the biggest thing is apnea is when you stop breathing, and sometimes that can be for mechanical reasons. If people are very obese or have poor structures within their throat, where their airways tend to collapse, and the person will actually stop breathing in the middle of the night, and the caregiver will hear them stop breathing. The next day, they'll frequently have cognitive impairment, feel very drowsy. They'll might fall asleep out of the blue, sitting in a chair, sometimes while driving. Some people sitting at a stoplight. If it's very severe, they may complain of headaches. And then there's also a central cause where you don't have all of the obstructive problems, but your brain, which drives all of your respiratory centers, it tells your body to keep breathing, isn't sending the right messages to your body to continue to keep you breathing. And in that setting, you'll also note that the person would stop breathing.
The caregiver often is the best historian about that.
Absolutely.
Because they typically, at least in the obstructive kind, which is probably the more commonly seen one, the caregiver talks about how loudly the person snores and that they may stop breathing and all of a sudden kind of wake up with a start to get that that breath in. So
Mhm.
they're often aware. Now we use this term sleep hygiene, which is a curious kind of expression, but what are some of the general approaches to sleep hygiene that we usually recommend that
Right.
might be helpful?
Sure. So, um, the the kind of dietary lifestyle things that we find most commonly impacting people's sleep are caffeine intake and alcohol intake. So it could be in tea, it could be in coffee, it could be in soft drinks. But we'll talk to some people and they'll say, "I'm not sleeping. I can't sleep." And we'll ask them, "Well, how many cups of
Mm.
tea do you drink a day?" And they'll say, "Well, I drink 8 cups of tea a day." And so it's really the
It helps me
caffeine
relax.
that's a
That's
stimulant,
right.
right? That's
Yeah.
that's pushing them over the edge. So avoiding caffeine, decreasing caffeine consumption to manageable levels, or
Earlier
shifting
in the
it
day. Yeah.
earlier in the day. And the same thing with alcohol. So people frequently will experience the fact that they'll have some alcohol and it will help them get to sleep, but actually changes the way you sleep. And so normally you're cycling through every 45 minutes or so these different phases of sleep. And alcohol doesn't allow you to cycle through normally. It keeps you just unconscious. And then often in the middle of the night, you'll have a rebound effect where your sympathetic nervous system gets engaged. And so you're really not getting high quality sleep. And so
I think
avoiding alcohol intake is also important.
this is, I guess, a theme that we might come back to with some of the medicines that are sometimes used for sleep. Is they might help with some aspect of the sleep issue, like maybe help you to fall asleep if you're having problems falling asleep, but that the quality of the sleep and the normal cycle of what happens in sleep
Yeah.
may be disturbed by some of those medicines in the same way that the alcohol can kind of disrupt things.
Absolutely. The other things with sleep hygiene, so exercise is very stimulating. So, exercising late in the evening might not be a great thing because it causes you to be stimulated. But exercising during the day or early on in the morning will bring about a certain degree of fatigue later on that will actually help you to sleep. It's also good for your mood and
Mhm.
helping with feelings of anxiety, diminishing those feelings. So all of those things are important. Avoiding screens or whether it's on your tablet or an iPhone or computer screens before your bed, before you go to bed. Trying to keep a television set outside of the room. So some people will watch TV in the room and then go to bed directly afterwards. So that's not a good thing. And then trying to keep the bedroom only for sleeping purposes. So if you're working or studying in the room and then you try and go to bed, you may have a negative association and not have as easy a time
It's like your
sleeping.
brain begins to associate the bed with other types of activities other than sleeping. So you might stay awake and think, oh, it's work time because I'm working in bed. I guess the other thing that we usually tell people is trying not to nap
Right. Yeah.
and trying to kind of wake up at the same time every morning as much as possible. Those things are often easier said than
Right.
done.
Going to bed at the same time and waking up at the same time, establishing that routine makes a lot of sense. And then for people that do struggle with frequent urination overnight, keeping their water intake
Mm.
before a certain period. And then for people as well that are on water pills, shifting those earlier in the day so that they're not taking a medication that may make them pee and keep them up at night. So,
For males, sometimes having a urinal
yeah.
by the bedside might at least diminish the risk of waking up and traveling to the washroom, maybe a risk of a fall.
Absolutely.
But not everybody benefits from that. So. In terms of thinking about some of the specific types of dementia and specific sleep disorders, maybe describe a couple of those conditions and what the caregiver might notice.
Sure. So, um, probably the most common specific sleep disorder that we'll see or a parasomnia would be REM sleep disorder. Normally, during the REM sleep of phase, you have muscle atonia, meaning your muscles are just flat and they cannot move. if there's damage to certain parts of the brain that regulate sleep, and again, I'm not sure if all of this is specifically worked out from a science point of view, but you lose that your body's ability to stay calm while you're having dreams. When you lose that ability, people may actually start to act out their dreams. This could include yelling or screaming out. It may involve them thrashing about in the bed, which caregivers need to be very aware of, because there are cases where caregivers can get injured.
Yeah, just from like
the
assaulted.
thrashing around, or and people may get up out of their bed and be around the room.
So this actually ties in with one of the questions that just came in from Hamilton, which is about sleep issues and different dementias, and specifically talking about Lewy body dementia. And both Parkinson's disease dementia and Lewy body disease are associated with this Rem sleep disorder, which can cause people with those types of dementias to have this parasomnia, where they have these abnormal behaviors. It's like they're in the dream and acting out. And if they're having a dream that's particularly physically active, they may be thrashing around. They might injure somebody. They may be calling out and speaking. So they may be waking up the caregiver if they're sleeping in the same room or the same bed. So
REM sleep disorder is interesting in that there are people that have REM sleep disorder that don't have dementia, but if you're in your 60s, let's say, and you follow people over time, large proportions of them, after 5 or 10 years, up to 60 to 80% of those people will go on to develop Parkinson's disease or Lewy body dementia. So there's something with the pathology or the injury to the brain that's altering sleep very early on, and that's not dissimilar to people complaining of losing their sense of smell before they develop the Parkinson's disease or Parkinson's disease dementia, or dementia with Lewy body, or becoming constipated many years before they develop it.
And dementia with Lewy bodies or Lewy body dementia is not always quite as easy to diagnose. So the presence of the REM sleep disorder may actually be helpful as one of the elements to the
one
diagnosis.
of the supporting diagnostic criteria.
Yeah. Are there any other specific types of sleep problems that are sort of characteristic of one type of dementia or another?
Well, hypersomnia, in fact, is also characteristic of dementia with Lewy bodies. One of the differentiating factors from dementia with Lewy bodies versus vascular dementia is if people are sleeping more than 2 hours a day, they may also slur their speech in the middle of the day as well, or have fluctuations in their cognition associated with that.
So hypersomnia, too much
sleep, right?
And that would particularly be shown with this sort of excess sleepiness during the day, maybe like either napping or sitting in a chair, falling asleep, and low energy.
Yeah.
Okay.
And then I think insomnia is more common across all dementias. If they're the kind of the later on in the phases, is the parts of the brain that regulate sleep are damaged as well as the rest of the areas that cause cognitive function, or that are responsible for cognitive function. So again, that baseline architecture gets distorted as well. The general sleep cycling through that takes place.
So there's distortions or problems with the normal sleep cycle, but then there's also problems with the general day-night sleep-wake cycle. And I'm going to say that's one of the things that I think is really challenging for caregivers, both at home and in long-term care, where the person with dementia may be waking up, sleeping during the day and waking up and awake for much of the night at times.
So, and I would find that for whatever reason, Parkinson's disease dementia and dementia with Lewy bodies have the largest sleep issues. People with Alzheimer's disease have many sleep issues, some of which we've described earlier on. And then vascular dementia, a little bit less. That's not hard science, but that's what our clinical experience is.
I'm going to go take a couple of other questions, and then maybe we'll come back to some of the various treatment options. So here's here's one. Does melatonin help with Alzheimer's patients?
It doesn't seem to. We were discussing some of the most recent science before we came on air, and there's no hard and fast evidence that melatonin helps or has a large impact across Alzheimer's disease patients in studies. However, there are very few side effects. There's not seemingly any change in a major way to your normal sleep cycling. There's no addictive properties of melatonin or long-term side effects. So, and it's relatively cheap. So we don't know. It may be effective in some segments of the population or subsegments of people that have dementia. So we welcome people to try it, but it's not something we heavily recommend that's going to solve all of your sleep problems related to your Alzheimer's disease.
The scientific evidence does not strongly support that, when people are doing the studies, they're not seeing a strong benefit, but adverse effects are, very limited. It is the body naturally produces melatonin. There's a good theory about why it should be helpful, but the science hasn't really panned out.
Right. And melatonin might be helpful for Rem Sleep Disorder, which is a specific disorder you would use to treat melatonin. And there's some lower quality scientific evidence to support that, which is good. And then really to your point about comparing it to the other sleep options. So maybe we should talk about those a little bit.
And actually this ties in, I guess, one of the other questions is, as a caregiver, what can I do to get more sleep? So probably talking about, well, what are the various management or options to improve the sleep of the person with dementia? Although obviously the caregiver could have a primary sleep problem themselves. I think in many cases, if you can improve some of the issues with the person they're caring for, that may help. So yeah, what are a few of the treatment options that you would typically recommend?
Every time that we start these conversations, we always say, what are the non-medication approaches? So it goes back to what we were talking about with respect to the sleep hygiene, right? So having people or giving the person with dementia a very predictable schedule, things that are routine that they don't have to think about. So they get up, they have their breakfast, they go about their daily activities. There's a pre-bed routine that they go through as well, and they're in bed generally by about the same time. We were talking about people getting up and being confused, putting on their daytime clothes or starting to make breakfast. So trying to keep those elements out of the kitchen or avoiding any sight of their daytime clothing as well. Making sure that we all have different preferences. You could be too hot or too cold, but trying to get it just right for whatever that person's specific preferences might be. Trying to provide people with a light snack before they're going to bed. Sometimes people will wake up hungry in the middle of the night. So you obviously don't want to give somebody a large meal, but giving them something pleasant to eat in a small quantity to avoid that is also good. And then avoiding medications that may cause sleep problems. So some of the cholinesterase inhibitors are associated with nightmares or things like that. Medications that might cause hallucinations later on. Obviously you want to avoid them, but in particular, some medications can cause hallucinations later on in the night.
If you can't avoid using those medicines because they're important for the person's care, can you shift the timing of the dosing, or at least to see if it helps?
Yeah. And I think we touched a lot about that on some of the other medications, but just being mindful of what medications people are taking at what times.
I'm going to say too, it does depend a little bit on, there are other types of sleep disorders that we haven't talked about. And for sure, some medicines that are commonly prescribed, like some antidepressants, can cause problems. Like people have maybe heard of restless leg syndrome, which can disrupt sleep, or even just sort of restlessness as a side effect.
Right.
So again, it goes back to, if a medicine's not clearly helping, it might actually be contributing to other problems. So it's always good to look at the full list of medicines, get rid of anything that is not 100% helping, because some of those medicines might be disrupting sleep, which is maybe causing more problems than the benefit of the medicine. Let's take a couple more questions, and then we'll talk about some of the medication options. Here's a question saying, does the transition from sleep to wake change with Alzheimer's disease? So I guess that maybe that's a question about the sleep cycle generally, or maybe it's a question around morning wakening in terms of changing from sleep to wake.
In Alzheimer's disease, sleep does become more fragmented, and the cycling does change with the damage to the brain. So people are more likely to transition between sleep to wakening more frequently throughout the night. But I don't know anything specifically about the nature of that change from sleeping to waking.
One of the things that we, as psychiatrists, one of the things we get asked about sometimes are the types of either illusions or hallucinations that might occur right when somebody's either falling asleep or waking up. So we have fancy words for those. We call them either hypnopompic or hypnagogic hallucinations. And actually, many people have those types of experiences where they may see things or mistake objects or people when they're just falling asleep or waking up. That's actually considered within the realm of normal. But I would say that people with dementia may have a longer period of confusion trying to understand or interpret that phenomenon. So that's one of the things that you might see in that transition between sleep and wakefulness. So here's another question. Dad is sleeping too much, about 5 to 6 hours in the daytime and all night. He's mid-stage. Is this normal?
It does not sound normal to me to be sleeping 5 to 6 hours in the daytime as well as sleeping at night. And obviously, we give no specific medical advice, but that's somebody that you consider sleep apnea in, right?
It seems like excessive daytime sleepiness.
Excessive daytime sleepiness. And so it may be partially related to the Alzheimer's. We don't know anything about this person and the rest of their medical history, but with the excessive sleepiness, if there's no sleep apnea, you really do cue into dementia with Lewy bodies as well. So I do think it's a problem. Most people do not sleep 5 to 6 hours a day. I definitely have a formal medical evaluation by a specialist in this situation.
The what I would say one sees a little more commonly, as you described, is if somebody's sleeping that much during the day, they're awake during the night.
Absolutely, it's the day-night reversal. And then I didn't mention the medication, so we don't know what medications this person is on. So sometimes we find people have a sleep problem, and then they're slowly titrated up on the medication. Then they start sleeping through the night, but then they start sleeping into the day because they're over sedated.
Yeah.
And this might happen in the setting where somebody comes into hospital, they're very sick and agitated for whatever reason. They have dementia when they're in there. They had some bad infection. They get put on a higher dose of the medication to help them sleep while they're in hospital and settle down, perhaps their delirious episode, but then they're discharged home.
And they're on that sedative.
Feeling better. They're in their own home. They're sleeping better. They're in their own bed. And then it's too much. So I'd really check into the medications as well, which the medical specialist should be able to look at all of these things in combination.
Here's a non-sleep question. My mother has severe Alzheimer's and has no sense of smell. I also don't have a sense of smell. Is there any way to find out if I'm at high risk of dementia? I guess what I would say is the damage to the nerve that's involved in smell, it is actually the most commonly damaged of what we call the cranial nerves. So while there may be some risk or predictive value, which you talked about a little bit, there's a lot of other reasons why somebody may have had damage to their sense of smell. Right now we don't have great ways of predicting risk of dementia that are in normal clinical practice. There are some, people who have strong family histories of early onset dementia. There are some genetic tests. Are those done in routine clinical practice outside of sort of
N-
specific genetic studies or research?
No, not right now. People can request them. So you're talking about the amyloid precursor protein or the presenilin um, mutations, but that's really clearly an autosomal dominant. Somebody had it before you, you have
Yeah.
it, and you can clearly chase it. Much more commonly, though, are people that have first degree relatives that have dementia, and that does increase your risk. So, there's dementia in my family. That means I'm at a slightly increased risk, but I don't worry about it because generally the risk is so small and there's nothing I can do other than what I would be doing
So I
day to
would
day
say,
anyways.
it depending on your age and stage and other health,
Hmm.
maybe check in with your primary care practitioner. Check out our lesson on promoting brain health because those are all things that you can do.
Hmm.
And if there are concerns, there you could have some baseline sort of bedside cognitive testing done. But other than that, I don't know that there's anything else that.
No, the other one I would mention for screening would be like an ApoE4, um, but that's not commonly done
Yeah.
also, and it's not. I mention it because those are the names that people will bring up with respect to testing, but they're not reliable tests where I can give you a specific percentage. Like you're an 80%
Yeah.
chance of developing this in the next 10
And
years.
and
It's not that helpful.
I guess I would just reiterate or state again that there are lots of like the cranial nerve that is involved in the sense of smell is frequently damaged. If you've ever
Right.
been in a car accident or even a kind of whiplash injury, it's not unusual for the sense of smell to be affected by that kind of injury.
Yeah.
Here's a question from Halifax. A particular problem in long-term care is the resident who doesn't sleep during the night, but is also a wanderer, keeping many other residents awake as well. And I guess this happens at home, keeping the caregiver or the family at home, causes a lot of cranky people the following day. Is this something that you see in your practice?
I don't see a, I don't see a lot of people in long-term care.
Okay.
But we do have quite a few people that have sleep related problems, and I think um, we always go back to why is the person wandering in the first place. Are they wandering, or are they up because they're scared, or they're
Hungry or yeah.
anxious, or they're hungry, or they have to go to the washroom? um, there are many things that people are respond to in their environment. So we always go back to that, and then also assessing them for the medical issues we
Yeah.
described um, previously. And then you've assessed them and you haven't found any of those things. Then you go back to the sleep hygiene issue and going back to all of the different things we talked about with respect to that. And then if perhaps it's a last resort and everybody is at the end of their rope, then we may consider a medication if that is something that's in keeping with the patient's values or it's in keeping with their substitute decision maker and their family's values.
I'm going to say that my experience from long-term care is that this is actually a very common
Right.
issue,
Yeah.
and the person who's wandering may also, go into other people's rooms. So for sure, they're potentially disrupting. One of the solutions that can be used, although it depends on staffing levels, is to have a bed alarm
Hmm.
so that at least before the other person gets into a safety issue
Right. Yeah.
or moves into another person's room, the staff might be alerted by the bed alarm going off, and the person can then be maybe redirected back to the room and have some kind of a consistent behavioral plan to say the same thing like a ritual
Absolutely.
and a behavioral plan to redirect the person back to the bed in the hopes that they might be able to fall asleep again. But
Right. Get
uh,
them a warm cup of milk or something.
yeah,
And right.
I feel like this is a really common
Very common.
challenge. So.
Yeah.
Here's a question from Mexico. My husband has Alzheimer's and often nods off during the day. He will immediately awaken and say, I was just resting, but actually he was really asleep.
Hmm.
Is this a problem? He seems to sleep well at night.
I don't think so. I wouldn't worry about that. It's unless similar to the previous question, they're sleeping for, more than 2 hours during the day, I don't think it's that big of an issue. People can get confused on whether they're sleeping or not, but I don't think it's that big of a deal as long as there's no consequence from it. So if they're able to sleep at night, then I wouldn't do anything about that.
Yeah, I guess if the normal state of energy
Hmm.
seems relatively good when awake. I mean,
Yeah,
there are some other like very rare sleep disorders,
like narcolepsy,
things like
right? So
narcolepsy,
yeah,
but that doesn't sound like it. I suspect it's been a change to the normal sleep pattern related to the
right.
dementia.
If you're not falling asleep mid conversation
Yeah,
or falling
I'm
asleep
falling.
repeatedly throughout the day, or yeah, or falling, yeah.
So why don't we talk a little bit about some of the medication strategies? And I guess it's good to just to restate our caveats. You know, we're not giving medical advice per se. We're trying to educate you on the range of different medications. And non-medication strategies are almost always the first things that should be tried with respect to sleep. And there's all kinds of limitations in the quality of the scientific evidence to support medications. But I think, you know, as clinicians, we respect the fact that caregivers and people with dementia exhaust all those other possibilities and are exhausted
Right.
and may be in need of some form of medication, at least as a trial. So let's maybe talk through some of those approaches.
Right. And I think, a point to discuss is in spite of the limited evidence, there are some clinicians or physicians that have more or less experience dealing with the medications, what their specific indication is, and what the side effects are for monitoring. So it's worthwhile making sure that you found somebody that's very comfortable
Mm.
using medications like this, so that they're watching very carefully to make sure that the patients don't experience side effects. So a very common medication is a tricyclic antidepressant. An example would be nortriptyline or amitriptyline, Elavil. A challenge with these medications, they're great because they're sedating. They're good because they can be used in chronic neuropathic pain or nerve-related pain, but they have really strong anticholinergic side effects where they may cause hallucinations, they'll cause very dry mouth, they'll cause urinary retention, they can cause constipation, they can cause confusion
Mhm.
themselves. So you have to be very, very careful. I never use them in my patients because there are other options. This
I think if they are going to be used or we see them used, it's they're often used at very, very low doses. So
Right,
dosages that are much lower than the dose that we would use if we were treating somebody with those medicines for depression.
absolutely. Benzodiazepines, so you might hear of lorazepam, oxazepam, temazepam, uh, Valium or diazepam. So they're good in that they're sedating and they treat anxiety, so they can diminish that feeling of anxiety. The problem is that you can become accustomed or addicted to them in a way, addicted to them, period. And so you'll need them on a daily basis. And if you don't have them, you can go into withdrawal and get very anxious. Also, we mentioned the challenges with sleep architecture. So they put you to sleep, but you'll have some sort of rebound surge in the middle of the night. They're also associated with cognitive impairment, falling the next day, and motor vehicle accidents. So it can be very problematic if you're using them for sleep.
I think one of the things that you brought up is a really important one in that the potential transition from a hospital admission to home. Benzodiazepines are commonly used as sleeping medicines in the hospital setting, and they often don't get tapered off or stopped, or they're prescribed for the duration of a hospital. So many of these medicines should probably only be used as very short-term trials. But if they're used for, you know, more than 2 weeks, as you say, the brain and the body become physiologically dependent. So they get used to seeing that medicine and might be at risk of withdrawal. Or the medicines may start to accumulate in the body and the brain,
Mhm.
especially if the body's not breaking down the drug in the same way. And I agree with you, especially some of them are shorter acting. Those tend to be the better ones to use
Right.
as a trial, as a sleep medicine, because the longer acting ones really build up in the person's system. And so they may become more sedated during the daytime. They may have problems waking up in the morning. And as you say, there's always going to be the risk of the brain and the body getting used to it, and the risk of withdrawal if they're stopped abruptly.
And what are the shorter acting ones that you would use then?
Probably oxazepam.
Mhm.
That's lorazepam is not too bad. Those three that you mentioned are not bad because they're a little bit shorter acting, and if somebody does have any kind of liver disease, they're a little bit safer. But oxazepam is one of the shorter acting ones. But again, there's challenges if people are continued on short acting ones. Those ones cause really bad withdrawal when they're
Right.
stopped. So
And so I guess as opposed to clonazepam, which is longer acting, but maybe used to treat something like REM sleep disorder.
or for anxiety,
You're
we
right.
often want a longer acting benzodiazepine so that people aren't getting rebound anxiety. But those ones, longer acting ones, make less sense, I think, as sleep aids.
There's another class of medications. They're Gaba agonists. So they're slightly different receptors, but on the same system as benzodiazepines or alcohol even. So zopiclone is one commonly that we'll see in Canada. The good thing about them is that there's no withdrawal, there's no addiction. There, well, there are only case reports. So addiction is very common with benzodiazepines, but it's very rare with these sleeping medications. More commonly, though, is that they just stop working over a period of time.
Mhm.
So you're not addicted to it, but you took it for 8 weeks and now it's just stopped working for you, and you won't work. It
Which
won't
is
work.
an issue with benzodiazepines as well, that your body, your brain may grow tolerant
Right.
to the dose. So a dosage adjustment may need to be done. But again, probably better that you're not using any of these medicines as longer term solutions, but that if you're exhausted and none of the non-medication approaches have made a big enough difference, that at that point, you might have a brief trial to see if a medicine might help. So.
And these medications are harmful in the same way that benzodiazepines are, in that they have an increased uh, risk of the adverse events we talked about previously the next day. But the advantage is that they don't alter the basic sleep architecture uh, to the same degree as the other medications do. Um, Atypical antipsychotics are commonly used, so quetiapine, olanzapine, and risperidone. The challenge is the side effects. So people on these medications can develop a Parkinsonism or have slowness of movement or tremor or stiffness in their muscles. They may get the sense of restlessness or the
Yeah.
akaesthesia or movement of their mouth in abnormal fashion. They're also associated with drops in your blood pressure when you stand up, urinary retention, so not being able to go to the bathroom. They can cause confusion as well among certain people.
I think to me it's been kind of interesting that these are really off label.
Absolutely, yeah.
Like they're not designed as sleeping medicines. But I agree with you. We see, I'm going to say particularly the quetiapine, or Seroquel is its trade name. It seems to be prescribed frequently, and there's just not a ton of evidence to
Right.
support it in this role. I'm going to say that this is where, if for whatever reason there are, other symptoms like psychotic symptoms that might warrant treatment with an antipsychotic, and the person has a sleep issue,
Mhm.
then maybe it makes sense to, choose a more sedating antipsychotic. But for me, I find it perturbs me that
Mhm.
how commonly medicines like the atypical antipsychotics seem to be used at low doses, but as sort of primary sleep medicines. It doesn't make a lot of sense to me.
Antidepressants I should have mentioned earlier because I think they're also much more frequently prescribed. So trazodone or mirtazapine are commonly
Yeah, actually, there's
sedating
good.
medications.
So actually, somebody sent in a question just now
Great.
asking about trazodone, and that is one of it's again an older sedating antidepressant, anti-anxiety that is almost never used as an antidepressant anymore. Its most common usage at lower dosage is probably as a sleep aid. Doesn't tend to disrupt the sleep rhythm as much. Not a ton of great evidence to support it as a sleep medicine, but commonly used. Also used sometimes for agitation or aggression. There's another question about sertraline. That's an antidepressant known as trade name Zoloft. Again, indicated for the treatment of depression and anxiety. So those things can both result in sleep disturbances, but not a sedating antidepressant and not something that we would ever recommend as a medicine to help with sleep as like a sleeping pill. And we're running down on time, but it wouldn't be a live event if we didn't have a cannabis question come in because it seems like we cannot escape it. Any evidence for CBD and THC at night?
Well, I'm not a cannabis expert, but we've discussed this before in that there doesn't seem to be any high quality evidence to date that suggests that they're useful for a lot of different medical conditions, in particular sleep. I know THC, depending on the strain, can be a little bit more sedating or not. CBD is not supposed to be sedating, but I suppose if you're one of the people that it works for to control your pain, then again, it might be an indirect effect or uh, it may have an immediate benefit on anxiety for some people if it mellows them out a little bit, but I don't know about the sleep architecture effects and what that looks like if you take THC or CBD for long periods of time for sleep. So I just don't think there's enough evidence to recommend it at this time. And hopefully in the next,
I think we'll
5
see a
years,
lot
we'll figure
more
it out.
scientific evidence over the next couple of years. I know there are some sleep specialists that are recommending trials under certain circumstances, but those are typically not in the setting of dementia, and some of them are actually in the setting of particular other nerve or muscle conditions. So I'm going to say not enough evidence to recommend it now.
One thing I just wanted to mention though, so we did mention restless legs in passing, but it's such a common parasomnia or sleep related issue. And so just talking about that, it's when people feel an abnormal sensation in their legs, it can be while at rest or right before they're sleeping. They move their legs and it actually makes them feel better. Really common and really important to get worked up for iron deficiency. And make sure that you're not on some of the other medications, so some of the antidepressants that you were talking about, SSRIs or SNRIs, or even some antipsychotics. There's treatment for it, but that's a really common thing that people experience.
And it should be assessed probably by a sleep specialist or at least a general internal medicine doctor or a neurologist.
And all of these, the advice that we're given, I think we're really good on the medication dementia side, but sleep is an area of specialty on its own. So as you're saying, if there's any big major problems with sleep that, we can't deal with on a more superficial level, or certainly if there's Rem sleep disorder, we refer those to sleep specialists to have them work it up because they're very specific diagnostic criteria and it's very nuanced.
So that's all the time we have for today. Really important topic. Want to thank Dr. Sztramko and
thank you.
Funding for the iGeriCare initiative was originally provided by the Center for Aging and Brain Health Innovation, or CABI, powered by Baycrest. Really fortunate to have had additional support from the Igera Center at Hamilton Health Sciences, McMaster University, the Alzheimer Society Foundation of Hamilton Halton, Hamilton Health Sciences Foundation, our team here at the Division of E-Learning Innovation at McMaster. Grateful to the studio. So thank you to the McPherson Institute. Our next live event will be at the beginning of February, February 5th at 1 p.m. Eastern. And please fill out the survey. Let us know. You have a chance to vote for the topic of the next February live event. So please give us some guidance on what you'd like to see, any other comments or questions. And again, we thank you so much for joining us. There is a donate button in the top right corner of the website. And so in addition to teamwork making the dream work, go donations also help to fund the teamwork that makes the dream work. So we look forward to seeing you again in February.